Insuring the public against big healthcare expenses is a challenge, though it's not clear that a government-run health plan could make it happen without sacrificing either quality or access. Arnold Kling, author of Crisis of Abundance, Rethinking How We Pay for Healthcare, believes the values that drive healthcare reform are often at loggerheads, and the government's role should be limited. He spoke at a Capitol Hill briefing June 2, 2009. The full event is available at cato.org.
Healthcare costs are driven to a large extent by extravagant use of medical procedures that have high costs and low benefits. So I think in general, healthcare policy wonks understand this. The healthcare policy wonk that was interviewed in the thing 6 weeks ago is Barack Obama. Obama, I think if he and I were sitting on a panel in a relatively private setting discussing healthcare and what's going on, I don't think we would be that far apart. But as a politician and president, he has other responsibilities, and I think those other responsibilities will lead him to deal with healthcare in a way that's very different from what a policy wonk would deal with. Okay, so that's sort of a prelude to this. Let me just whip through the five points about the economics of healthcare, and these are, again, all in the book Crisis of Abundance. First, picture a triangle with the top is sustainability, affordability, sustainable, affordable healthcare system. Over here is a system where people have unlimited access to procedures. That is, there's no rationing of healthcare. And then over here is people don't have to pay for their healthcare services. They're insulated from having to pay for them. And so what we want as individuals is to have unlimited access to medical services without having to pay for them, as we want to be at include both these points in the triangle. The problem with that is that if you give everybody unlimited access to medical services without having to pay for them, what you end up with is an unsustainable, unaffordable system, so you have a problem with the top of the triangle. And you can't be at all 3 points in the triangle at the same time. That's kind of my first point. And where I think the debate logically should be, assuming that we understand the need for a sustainable, affordable healthcare system, the debate is between how you're going to achieve that, whether you're going to restrain people's use of medical services by rationing or by self-restraint based on people confronting the cost of their services and having to pay more out of pocket and make different decisions based on the having to pay out of pocket. So the real debate ought to be between rationing by centralized management or rationing by the decentralized price system. I've never met anyone from the left who wants to have that toe-to-toe debate. They've got all sorts of debating tactics for evading that. And that's, so I've never actually engaged in that debate. It would be. I think I could debate that from either side. By the way, I could make a case that it would be morally superior to have government do rationing. I mean, I don't believe ultimately that is the right answer. I think that's, I don't think the left is hopeless if they try to get into that debate, but they'd rather not. Okay, so that's the first point, is that there's this triangle. You can't be at all 3 points on the triangle. Second point is that there's a large gray area in medicine. That is, the gray area is procedures that are neither absolutely necessary nor absolutely unnecessary. In the handout with the interview with the wonk with Barack Obama, he mentions that his grandmother had terminally ill cancer and had hip surgery. And you can see from the tone of it, he's not really sure that hip surgery was really worthwhile in the end, because her health went downhill rapidly afterward. And ironically, there's a lot of similarity between that and what I experienced with my father about 1.5 years ago. Again, terminally ill cancer, hip surgery, and then just a rapid downhill from that. And so that's a morally fraught issue, and that's so it's maybe a more extreme example of the gray area of maybe it's not absolutely necessary, maybe it's not absolutely unnecessary. There are plenty of other examples of the gray area. The one I like to use the most is for those of us over 50, happy birthday, you're supposed to get a routine colonoscopy screening to screen for colon cancer. And that's not absolutely necessary. In Canada, they don't do that. In Canada, they don't have the equipment or the specialists needed to do colonoscopy screenings on healthy people to screen, as a screening for colon cancer. And that may be the right decision. I wouldn't be surprised if the cost per life saved from doing that is, on the order of $1 million or perhaps more. And so from a bureaucrat's point of view, you could say, well, if I'm going to optimize the mix of services, I'm not going to spend $1 million to save a life by putting everybody through over 50 through colonoscopy screening every 5 years. More likely what they're saying is, of all the ways to ingratiate ourselves with voters, colonoscopy screenings is not, that's not going to win a whole lot of popularity contests, so maybe that's why we don't allocate a whole lot of resources to that. I can see a lot of people are too young to appreciate what experiencing a colonoscopy is like, so you don't realize that that's not a way to win a popularity contest. But that would be something. Now, so it's not absolutely necessary that you go through this protocol of having a colonoscopy screening every 5 years. Having said that, I've done. I go through that protocol. I've looked at the research on it. I buy into it. I mean, it really is a way of preventing colon cancer. Not just spotting it early, but actually preventing. So, so I would say that the colonoscopy protocol is not absolutely unnecessary either. It's not absolutely necessary, not absolutely unnecessary. And I think it's very important to understand this gray area. Peter Orszag, who was the head of the Congressional Budget Office, is now head of the Office of Management Budget, will throw out this figure: 30% of health care spending in this country is unnecessary. And it's helpful and unhelpful for him to say that. It's helpful in the sense that it points out where the really big driver of excess costs is in healthcare spending in the U.S. comes from our choice of medical procedures. So in that sense, it's helpful to say something like 30% unnecessary. But it's also very unhelpful to use the term unnecessary as if this is a binary issue, that there's a very bright line dividing necessary and unnecessary health care. Because the truth is there's a huge gray area. My guess is that the amount of spending on procedures that is absolutely unnecessary is probably way less than 5%. It's nowhere near 30%. On the other hand, the amount that's spent on clearly necessary procedures might only be a quarter. And then in the middle is this huge gray area, 2/3 or more of spending that's neither absolutely necessary nor absolutely unnecessary. So that's my second point, that there's a very big gray area. And when you do, so when Peter Orszag talks about doing comparative effectiveness research, I'm actually all for comparative effectiveness research, but I don't think it's going to create a dividing line between absolutely necessary and absolutely unnecessary. I think what it's going to do is going to shed more light on this gray area, but it's not going to dictate what ought to be done in every case. It's not going to dictate to individual doctors or individual patients what the right choice should be. At most, it'll give a little bit more statistical guidance, but it is not going to be is not going to divide the world into necessary and unnecessary procedures. There will still be a large gray area. We'll just know a little bit more about some of the probabilities involved.
Arnold Kling is author of Crisis of Abundance: Rethinking How We Pay for Healthcare. The full Capitol Hill briefing is available at cato.org.